For today's presentation, just a few housekeeping notes. If you have a question, please utilize the text chat box. We will be checking those at the end of the presentation. So when Dr. Dunga is finished with her portion, we will be answering all questions at that time. We have a feeling that maybe some of your questions will be answered as we go along through the program. Right now, I would like to introduce you to our moderator for this evening, Dr. Chris Cooper. Dr. Cooper earned his medical degree from the University of Cincinnati, where he graduated as class valedictorian, and then he went on to his fellowship and residency at the Brigham and Women's in Boston, which is a part of the Harvard system, and that is where he received his interventional cardiology fellowship. Dr. Cooper has been a part of the University of Toledo for more than 25 years. He has conducted research receiving multi-million dollars, up to $25 million for his research from national funded agencies. He has been published in numerous journals, such as the New England Journal of Medicine. He's also recognized by his peers across the country as he is a fellow of the American College of Cardiology and the American Heart Association and the American College of Physicians. I will now turn the meeting over to you, Dr. Cooper.
Thank you very much for the introduction, Jennifer, and hello to all of our participants tonight. So as Jennifer mentioned, I'm Dr. Christopher Cooper, the Dean of the College of Medicine and Life Sciences and Executive Vice President for Clinical Affairs here at the University of Toledo. As a brief introduction, our College of Medicine is in the business of discovery through nationally recognized research, patient care, and training many of our region's physicians and scientists and other health professionals. The compass that guides our College of Medicine is our mission to improve the health in our communities and our region. To that end, what we've identified as a great need in our community for information about COVID-19, vaccines for COVID-19, and the impacts on vulnerable populations, including people here in Northwest Ohio. This afternoon, we have a really exciting panel of nationally recognized leaders that include virologists that work with the COVID-19 virus and other potentially lethal viruses. We have infectious disease specialists that work on the front lines of COVID care and also lead many of our region's responses to the COVID pandemic, and who are nationally recognized for that work. And we also have a pharmacist with us who is leading UTMC's efforts to distribute vaccine. Our goal for tonight is to get solid, reliable information out to our community that you can trust. I want you to be able to trust the information you get. And I would like to take a moment to introduce our presenters and panelists. Tonight we're going to hear from Dr. Saurabh Chattopadhyay, who's a virologist and an assistant professor in our Department of Medical Microbiology and Immunology. He graduated from the Indian Institute of Medical Microbiology and did a postdoctoral fellowship in virology at the Cleveland Clinic. He's published over 51 peer-reviewed publications, presented more than 20 seminars, and currently has over $1 million in NIH funding to support his research. We'll also hear from Dr. Joan Duggan, who's an infectious disease specialist and a professor in our college, as well as a senior associate dean for faculty affairs and development. She earned her medical degree right here in Toledo from what was then the Medical College of Ohio, and then completed an infectious disease fellowship at the University of Michigan. She's received numerous awards and millions of dollars of research funding and has over 130 publications in her field of study. We're also going to hear from Dr. Jennifer Hanrahan, who's an infectious disease specialist and the chief of the Division of Infectious Disease here at the University of Toledo. She earned her medical degree from the Chicago College of Osteopathic Medicine and completed her fellowship in Cleveland at University Hospitals. She's written book chapters, abstracts, and peer-reviewed publications. She's passionate about education and mentoring of students, residents, and fellows, and is often invited to speak locally and nationally on COVID-19 in the clinical setting. I'm also pleased to introduce tonight to our speaker panel Dr. Jason Huntley, who's an associate professor in the Department of Microbiology and Immunology. And importantly, Dr. Huntley is the director of our biocontainment facility that studies live COVID-19 virus and other potentially lethal infectious agents. He earned his doctoral degree from Iowa State and was an NIH infectious disease fellow. Dr. Huntley has published prolifically, has given over 50 invited research presentations at national and international venues, and has been awarded more than $4.5 million in federal and other research grants. Importantly, and I think you'll be delighted to hear this, in January of this year, Dr. Huntley introduced Dr. Anthony Fauci at the National Biothreats Conference in Washington, D.C. And as you know, Dr. Fauci opened the nation's eyes to a novel and deadly viral pneumonia that was then sweeping through China, what we now know as COVID-19. So yes, our faculty member introduced Dr. Fauci. We're also going to hear from Dr. Russell Smith, who's the Chief Pharmacy Officer, Quality and Safety Officer, and an administrator at UTMC. Russ has more than 25 years of academic pharmacy experience. He oversees all clinical pharmacy activities for the University of Toledo campuses. He earned his bachelor's degree in pharmacy right here in Toledo from the University of Toledo and his doctor of pharmacy degree at the University of Shenandoah. Russ is leading the university's COVID immunization program. And finally, Dr. Travis Taylor is a virologist and an assistant professor in the Department of Medical Microbiology and Immunology. He received his doctoral degree in molecular microbiology at the University of Texas Southwestern in Dallas and was trained at the National Institutes of Health Rocky Mountain Laboratories. He has a number of publications and several million in grant funding from the National Institute of Allergy and Infectious Diseases, the agency that Dr. Fauci runs. I'm now going to turn over the presentation to Dr. Hanrahan. Dr. Jennifer Hanrahan, thank you so much.
Thank you very much, Dr. Cooper. So I'm going to speak very briefly. I want to make sure that everyone has plenty of opportunity to ask questions, and I think there's going to be a lot of questions about the vaccine. So, all right. Sorry, I'm not sure. Can I control the slides, or Jennifer, can you do next slide? Thank you. So basically what I want to tell you is that this is obviously you're all aware that this is a horrible pandemic, but I really want to emphasize that not everybody has been equally affected by this. And I'm still hearing people say that they think that maybe this is overblown or that it's really not as serious as people are making it out to be. And I've heard that even from people who are in the hospital for other things. So I just wanted to mention that on December 15th, we reached the grim milestone of having over 300,000 deaths in the United States from COVID-19. And if we keep going at the current pace, then we will easily double that number. So it's very important that everybody understands their role in stopping this and in getting the vaccine. There's a website called, COVID Exit Strategy, and that's where the map on the left side of the page is from. And if you look, you can look state by state to see what's going on. And basically, there's uncontrolled spread in every state in the United States, with the exception of Hawaii, which is heading towards uncontrolled spread as well. Next slide. So, one of the questions that comes up is, why not just wait for herd immunity? Eventually everyone will be infected and then we'll have herd immunity. So the problem with this is that if we wait for that to happen, there's going to be a lot of deaths in the meantime. And then the other problem with that is that the more this virus continues to replicate, the more opportunity there is going to be for mutations, and it's going to be more difficult to vaccinate everyone and to try to put an end to this. So the idea that we can just wait for herd immunity is really not, I don't think that's plausible. The percent of people who have to be immune in order to achieve herd immunity depends on how contagious the virus is, how long immunity lasts, and whether the virus mutates. SARS-CoV-2, the virus that causes COVID-19, has a reproductive rate of about 2.5 to 3.5, meaning that for every single case that you have, if you have people around that case who do not have immunity, then you will have an additional 2.5 to 3.5 cases. So what we know is that somewhere between 60 and 72% of the United States population will need to be immune for us to achieve herd immunity. If you look at the current seroprevalence, meaning the current number of people that have been infected in various areas of the country, it's estimated to be between 10 and 20%, depending on where you are in the country. So we're far from herd immunity, and we are really struggling right now with the number of cases that we have. Next slide. So I'm just going to briefly talk about both the Moderna vaccine and the Pfizer vaccine. And, you know, one of the concerns that comes up is whether or not these vaccines were rushed and whether or not these vaccines are safe. And I think it's very important for people to know that both of these vaccines went through rigorous clinical trials. These were randomized, controlled clinical trials where half of the people were assigned to placebo and half of the people were assigned to the actual vaccine. And the Moderna vaccine included more than 30,000 participants, and the Pfizer vaccine was given to over 43,000 participants and in the studies. And we have actually a great deal of safety data available. Prior to this, the Food and Drug Administration recommended that for a vaccine, to have about 3,000 participants in order to have enough information. These studies had more than 10 times the number of participants that were necessary in order to figure out whether or not the vaccines would work and whether or not they're safe. And I think it's very important for people to know that these studies were done completely. There were no shortcuts. They did not rush these vaccines to get them to market. I would also mention that both the Pfizer vaccine and the Moderna vaccine took great pains to make sure that they included people who have previously been underrepresented, including minorities that may be disproportionately affected by COVID-19. And both studies actually represent the cross-section of the United States. They're accurate in terms of the percentage of people that were included in the study that represent different ethnicities and races. Next slide, please. And this is just a graphic from the Pfizer vaccine site. I encourage you, if you have any questions, to please go and look at their site, and you can also look at the CDC website. So the Pfizer vaccine trial took place at 150 clinical trial sites in 6 countries, including 39 U.S. states. Again, over 43,000 people received the vaccine, and you can see the breakdown of participants on this slide. Next slide. So basically, you know, this is my plea to you to tell you we finally have a light at the end of the tunnel, but only if everyone does their part. So it's incredibly important. The only way that we're going to put an end to some of the unnecessary deaths that we're currently seeing is if everyone gets a vaccine. And with that, I'll turn it over.
Thank you, Dr. Hanrahan. Next up, we will have Dr. Huntley share his knowledge on vaccines.
All right, thanks, Jennifer. Thanks, Dr. Hanrahan. So I'm Jason Huntley. I'm a faculty member in medical microbiology and immunology. My lab studies vaccine development against pulmonary disease, primarily against bacteria, but we are, as Dr. Cooper mentioned, working with SARS-CoV-2 in our special biocontainment lab. Next slide, please. So Dr. Hanrahan talked about the virus, SARS-CoV-2. The vaccines that are being developed are focused on this protein in green, the spike protein. It's a surface protein on the virus that allows it to bind to a specific receptor in your lungs on cells. That's called the ACE2 receptor. By binding to it, the virus then enters cells and it replicates to very, very high numbers. It then is released in very high numbers and it ends up killing cells and causing massive inflammatory responses. Next slide, please. So the purpose of vaccination is to stimulate antibodies, and more specifically what we call neutralizing antibodies. Those are antibodies or immune molecules that can bind, inactivate, and kill the virus. And again, the purpose of these antibodies is to do two things. As you can see on the left, it's to block that initial infection process. If the virus is inactivated and cannot enter cells, it cannot replicate. And second of all, on the right, after the virus has infected cells and it replicates and kills cells, it can go on to infect other cells, but the purpose of vaccination is to block the infection of other cells. It's an exponential process, so vaccination induces antibodies that blocks that process. Now, of course, this is more complex because it turns out that B cells or B lymphocytes, these white blood cells you may have heard about, those are the cells that produce antibodies. Those also have to be stimulated. The data we have from both Moderna and Pfizer is that they do that. The antibodies also need to be stimulated, or the B cells need to be stimulated by T cells or T lymphocytes. So you need this very complex process of T cells that help stimulate the B cells and another set of T cells that actually can kill infected cells. And again, the data we have from both Moderna and from Pfizer indicate that you get antibodies, B cell and T cell responses. Next slide, please. So historically, even 5 years ago, this is how vaccines were developed. Most of you should have gotten, or if not, please do get vaccinated against the influenza virus. That's an inactivated vaccine, as you see here in number 1. Contrary to some urban legend, you cannot get the flu from the flu vaccine because it's inactivated or killed virus. We grow the virus in the lab. It's either chemically or heat inactivated and then given. The second type of vaccine, which many of us have gotten, are what are called modified live or modified attenuated viruses or bacteria. Again, in the lab, specific genes or mutations are made such that the virus or bacteria is mutated or it cannot cause disease, but it can teach your immune system to mount immune responses. You think about measles, mumps, rubella, that's a live attenuated vaccine. The third type of vaccine is a subunit. It means a portion of the pathogen. And again, think back to that green spike protein on SARS-CoV-2 virus. The subunit vaccines would target blocking that specific molecule. So, for instance, the tetanus vaccine, which is given, is a subunit vaccine. It's a portion of a pathogen, and then your body mounts an immune response against that. So historically, that's the way that we develop vaccines, but the problem is that that has taken 15 years or longer. Next slide, please. So what's amazing, again, is almost 1 year to this week, a number of us got emails or were part of listservs that noted that there was a virus or some unknown pneumonia sweeping through China. And here we are, 1 year later, and we have an FDA-approved vaccine. Yes, it is emergency use, but we have two, we'll see because the FDA is meeting right now, but in theory, we're going to have 2 FDA-approved vaccines. So let me explain what those are. You heard about the Pfizer vaccine, which was rolled out this week, and again, the FDA is meeting today to approve the Moderna vaccine. These are both mRNA. This means messenger RNA. Remember, your own cells have DNA, which is the blueprint, which makes you who you are, that produces proteins. Viruses have RNA, including this coronavirus. So both Pfizer and Moderna are an mRNA vaccine. It's a portion, the spike protein, is encoded in this gene, and it's surrounded, you can see here in blue, by a lipid particle that helps protect the RNA, and it also helps stimulate the immune response. So both of these vaccines are mRNA. When you get the injection of the vaccine, it goes into your cells. It produces the spike protein from SARS-CoV-2. The important thing to know is that mRNA is not DNA. It cannot insert itself into your genome. It also cannot cause mutations. Researchers have been studying RNA for 50 years. RNA cannot do that. So again, this is an extremely safe vaccine. The second type of vaccine that's being developed, and you may hear about in the next couple months, are what are called replication incompetent viruses. So both Johnson & Johnson and the Oxford vaccine, these are not coronaviruses. These are actually adenoviruses, which normally cause the common cold. These have been mutated, modified. In fact, one of these vaccines is a chimp or a chimpanzee adenovirus, where they've then cloned in the spike protein from SARS-CoV-2. And again, the purpose is to mount an immune response. So again, we've gone from 15 years or longer historically to in less than 1 year we have approved vaccines. This is a major milestone. Next slide, please. And as Dr. Hanrahan emphasized, next slide, please. These vaccines are very safe. They go through a rigorous testing and approval process. Again, the FDA is meeting right now. They've been in session for over 9 hours. There's thousands of pages of documents that go to support this data. And from what we know, they're over 95% protected. So very safe, very effective. There were no corners cut. And despite the rapid speed, this was not done improperly, right? There's a lot of data to back this up. There are questions about how long protection will last. We know from people who've been infected, antibodies last at least 3 months. The data from both Pfizer and Moderna indicate the same. We'll see. Perhaps antibodies and the immune protection will last longer. What about if the virus mutates? Well, in fact, we know from a number of studies, SARS-CoV-2, the virus actually has mutated. Both Pfizer and Moderna have done testing and proven that with about 70 different mutations, we know that already have occurred throughout the world, both vaccines protect and induce neutralizing antibodies that still neutralize or inactivate that virus. What about availability? I mean, you've all heard questions about it. We'll have to see. But as new vaccines are approved, I talked about the modified lives that are coming out. We're hoping that there should be more vaccines, more different types of vaccines that we can all get. Now, again, the important thing to note is for those of us with children, these vaccines are being approved for those 16 or 18 years or older. So there is not currently, nor is there a plan for a pediatric vaccine. I've heard that Pfizer is looking into that, but you need to hold your breath or cross your fingers for pediatric vaccines. Next slide, please. So what is University of Toledo doing? As Dr. Cooper mentioned, we're one of a few universities or agencies that have a biosafety level 3. It's basically a submarine where we can work with things like SARS-CoV-2, anthrax, plague, et cetera, without the community being infected. So this is a bubble where we can work with large amounts of virus without getting infected. And what's our question? We have actually multiple questions. The first being, we have some patients, we have doctors, nurses, et cetera, throughout our community that have been diagnosed positive for SARS-CoV-2 for months. So the question is, are they actually shedding live virus, or is it just that they have RNA that's being shed? The second question is, from the currently approved treatments, including dexamethasone, which is a corticosteroid, which can immunosuppress, do they shed more virus? Or with remdesivir, which should interfere with viral replication, do those patients actually decrease viral shedding? And then finally, we have some very talented investigators here who've developed an animal model. It turns out SARS-CoV-2 is very specific for humans. Yes, also non-human primates and minks you may have read about. But other than that, the animal models are not good for SARS-CoV-2. So we have an investigator who's knocked in the ACE2 receptor into rats, and right after the first of the year, we'll be studying infection in those animals. And the purpose is to better understand COVID-19 disease, that inflammatory process, and then use these animal models to help develop new vaccines, new drug treatment options. All right, and with that, I'll pass it off to Dr. Chattopadhyay.
Thank you, Joseph. Good evening, everybody. As you just heard, we are into a great tool, that's the vaccine. I'm now going to share with you another tool that is a new tool that we developed from our toolbox that's going to be applying to stop the COVID-19 spread in our community here in Toledo. And I'm sure you all have heard about testing yourself, how critical it is to test yourself for COVID-19. What I'm going to advocate now is that it is also critically important to test your wastewater, your household wastewater, what is called sewage. Why am I saying this? Because this has been used earlier for the detection of poliovirus outbreak. And there's a large number of studies that is showing that the COVID-19 infected patients, they shed the viral RNA into their feces. Therefore, the people shed the virus very, very early, immediately after the exposure to the virus. And very important thing is that both symptomatic as well as asymptomatic infections can be detected in the wastewater. Because you have to remember that asymptomatic individuals, they do not seek any clinical testing, but they can also be detected by this test. So what we're thinking is that this is a leading indicator of community spread, and that is independent of any healthcare seeking behaviors. So the raw wastewater that is collected from the wastewater treatment plants, they are tested for the viral signature or the viral gene copy. And these wastewater results that we get are then correlated with the case numbers. And this is a very, very powerful epidemiological tool that we are studying here in the lab. And as is shown in the picture, that the fecal shedding of COVID-19 can be used as a wastewater surveillance for a response to this outbreak. So our goal is to do the wastewater surveillance as a tool for public health officials to understand the COVID-19 spread in the community. Next. So in response to that, CDC has launched a nationwide wastewater monitoring system. And to address that, the governor of Ohio here has launched a statewide wastewater monitoring network. And I'm very proud to say that we are here at UTL Lab is one of those network laboratories. And we have collaborators from Ohio Department of Health and Ohio EPA, US EPA, and there are a lot of other labs from other state universities. And the data that we generate in the lab is then shared on the Ohio Department of Health COVID-19 dashboard. And these data are then publicly available. And what I would like to also point out is that if there is an alert generated, for example, there's a spike in the viral gene copy, then this is immediately transferred, this information, to the public, to the local health department. Sometimes we go out and then we come up with a press release. And often this also enforces additional testing. As you have seen here, I'm showing here that in Oregon, that's our neighborhood, that increase in COVID-19 in the wastewater led to additional testing sites in the community. Next. So what are we doing here in the UT? So UT is a part of the nationwide network, right? So we get the samples from the wastewater treatment plants, and then we run it through a series of tests. And then this group of investigators in my laboratory, and eventually we get the results that we then report to the Ohio Department of Health. And I would like to point out that this is the same type of test that we use to test a COVID-19 patient, that is called the PCR test. Okay, I'm going to share with you one piece of data here on the graph. In blue, you see this is a wastewater signal of the virus gene copy that we have collected over a period of time of last 7 months. And here I'm showing you the data that we collected from 3 local plants, that is Toledo, Oregon, and Lucas. They are serving our community. And in red, I'm showing you the daily case number in the Lucas County. And if you can focus on some parts of this, that late in the summer, early in the summer, that we saw there was a drop in the wastewater signal that was followed by drop in the COVID-19 case. And then again, early in the fall, we saw there was a rise in the COVID-19 signature in the wastewater that was followed by increase in the case number. Therefore, the wastewater results may provide a lead time for the healthcare providers to enforce increased testing as well as increased mitigations, for example, masking and social distancing, etc. So therefore, what I would like to leave you with is that your wastewater can provide an early warning of COVID-19 spread in your community. And I would like to thank my funding sources, and I would like to thank all of you. And what I'd like to also mention that I'm very, very hopeful that with the new vaccines that are coming, this wastewater signal is going to go down. With this, I'm going to pass it on to Dr. Travis Taylor.
Thanks, Dr. C. he has done such an amazing job establishing this wastewater network. So I think we should just publicly acknowledge the effort he's put in. It's really going to help us understand what SARS is doing in our community and on campus. So thank you, Dr. C. Hi, everybody. I am Travis Taylor. Dr. C and I are part of the Rocket Virology group here at UT. We're a group of virologists that spend a lot of time thinking about viruses, how they work, how to stop them. And this was all before 2020. So my goal here is to give you a brief overview of the currently approved COVID-19 antiviral treatments, highlight how they're different from a vaccine that we've been talking about, and finally to give you a snapshot of some of the research efforts that we've got going at UT. So I'm going to start with a couple of points of importance. We're developing new antivirals. So as Dr. Huntley explained, a vaccine is the best way to combat a virus before you are infected. But it's going to take a lot of time to get everybody vaccinated. And since we're all different, we may respond differently to the vaccines. Some people are better at making new antibodies. So this is why we got to continue to discuss masks and social distancing. So it's difficult to predict how susceptible each of us are to infection, especially to the more severe diseases. But this is where new antiviral treatments can come in, and we have a few that are now approved for use. For someone admitted to the hospital with severe COVID-19, a shiny new antiviral is one of your best options. So COVID-19 treatments come in a couple of varieties. The first is directed at preventing life-threatening symptoms of the disease. Dexamethasone is an anti-inflammatory steroid that prevents lung injury from the inflammation and has reduced the risk of death for patients on ventilators. On the other side, antivirals may be designed to directly target the virus to prevent infection and replication in the cells. This is how many of our more common antivirals work, like the ones we use to treat HIV and flu. Targeted treatment takes a lot of time to develop, so we need to have a solid understanding of the basic biology of the virus, how it works to be successful. Next slide, please. Fortunately, we've had opportunity to learn a lot about coronavirus biology over the last year. I'll next discuss some of the important parts of the viral life cycle that may be exploited as a drug target. There are some steps that we expect regardless of the virus we're talking about. We're talking about coronavirus or Ebola virus. Viruses are all parasites, so they're incapable of growing outside of a cell. So there are some steps of an infection that are always going to involve binding and entering a host cell. For SARS-CoV-2, that means binding to ACE2 receptor on a lung cell, as Dr. Huntley told us about. And this is illustrated in the cartoon on the right at the top. So once inside the cell, the virus starts making all of its own proteins and then many, many copies of its RNA genome. This is called the replication step. And over time, when sufficient materials accumulate, viruses will assemble and are released. A single infected cell may produce thousands of infectious viruses before it dies. So this adds up really quick. Next slide, please. The current approved antivirals prevent different steps represented on this cartoon. So from the top, bamlanivimab and Regencov-2 they both recently received emergency use authorization from the FDA. This was last month. They're both neutralizing antibodies that bind to the SARS-CoV-2 surface, it's shown in this cartoon, or to the spike protein on the surface, and they prevent receptor binding and entry. So this will prevent infection before it even starts. Your vaccination is always also going to produce these neutralizing antibodies. So this is the same kind of approach, but it's in a treatment form. Next slide, please. Remdesivir is the first FDA-approved SARS-CoV-2 antiviral. This is a drug that inhibits the copying of viral genomes, so it's inhibiting the replication states and shutting down virus replication. There's also evidence that remdesivir can inhibit other coronaviruses and even Ebola virus. So this is a great addition to our antivirus tool belt. Other potential antivirals are at various stages in the developmental pipeline, so we'll have to stay tuned to see what's coming next. Next slide, please. And yes, and finally, a few words on our research directions. So a surprising positive effect of this pandemic over the last year has been that it's encouraged crosstalk and collaboration across UT campuses. This is allowing us to leverage the various tools and expertise we have in abundance here at UT. I've highlighted a couple of our exciting new studies on the slide here. So on the left, my group's now working with the Department of Neurosciences to use a new innovative computational prediction approach to identify potential COVID-19 treatments. This is really, really exciting to be a part of this. And the first phase of the study is currently under review. But there's much to be done to evaluate whether these identified antivirals they work. So we're going to be testing them in cell culture and in animal models. And then second, on the right, a project funded by the Medical Research Society in Toledo is evaluating potential oxytocin to prevent COVID-19 disease. So we're working with the lead team in the Department of Psychiatry to complete live animal studies and aid in their human clinical trial. So this is definitely beyond what we normally do in the Department of Microbiology. But in addition to these studies, there are many ways that you can identify new drugs and antivirals from the basic science standpoint, which is what we spend a lot of time thinking about. Our rocket virology group is attempting to use all the tools available at our disposal now to pursue new options for treatment and, as Dr. C told us about, surveillance. So I'll stop there, and it's my pleasure to introduce Dr. Joan Duggan.
So thank you, Dr. Taylor. In the last 30 minutes, we've gone over some of the clinical aspects of COVID, some of the treatment strategies, prevention interventions such as vaccination, and ongoing research into the effects of COVID-19 that are occurring right here at the University of Toledo, and they're pretty exciting. But I want to take the next few minutes to talk to you briefly about the intersection between COVID and the social determinants of health. So in other words, I want to take a few minutes to highlight some of the patient populations, our friends, our family, and our neighbors, that are vulnerable to the consequences of severe illness from infection and an increased risk of death. So this is an older slide dating all the way back to August of 2020, which highlights some of the consequences of COVID-19 infection in our most vulnerable populations, the elderly. Now, I don't have a pointer, unfortunately, with which to call this out, but if you take a look, thanks, yep, perfect. So if you take a look at the bottom, we're still teasing out some of the science behind this, but this statistic actually illustrates one of the most heart-wrenching effects of this disease, which is the effects on the elderly. So if you look at the comparison group, which is healthy people 18 to 29 years old, and you compare the outcome for both hospitalization and death for our most vulnerable patients, the 85-year group and older, you'll see that the risk of hospitalization for people in the last bracket, 85 years and older, is 13 times higher than it is for a younger, healthy person. But death, the risk of death for people over the age of 85 compared to somebody who's younger who gets COVID is 630 times higher. So I'm going to say that again, 630 times higher. And this is amounted to a loss of elderly Americans numbering in the hundreds of thousands in our country. And the end now may just be in sight. Next slide. So in addition to the elderly, we have a number of patients that are vulnerable to severe illness with COVID. And some of the patients who are at increased risk include people who have cardiovascular disease, diabetes, or high blood pressure, people with chronic lung problems, including emphysema, and also infections that you traditionally think of like tuberculosis, people with cancer, problems with their kidneys, people who are overweight or smoke. So essentially, huge chunks of our society are at risk for severe illness and potentially a really bad outcome from COVID, including potentially long-term disability or death. Now, interestingly, there are some things that predispose patients to severe illness when they get infected with SARS, and some things that surprisingly don't. And I've listed just a few for our discussion today. So, for example, if you look right below the heart on this slide, you'll notice that it says men are more likely to have severe illness than women. And the reasons for this aren't totally clear. Next slide. But at the beginning of the epidemic in early 2020, we were very concerned that patients with HIV would be especially vulnerable to negative outcomes if they got infected with SARS-CoV-2. Turns out that's not the case. In fact, in multiple populations studied across several continents, HIV in and of itself doesn't increase the risk of a bad outcome. So if you're a 65-year-old man with HIV and diabetes and hypertension, statistically, you're going to have the same outcome as a 65-year-old man with diabetes and hypertension, but without HIV. Now, the reasons for this aren't clear, and it was actually somewhat surprising. On another note, there seem to be maybe some genetic factors that affect outcomes. So men are more susceptible to bad outcomes than women. Interestingly, it looks like people that have different blood types have different outcomes too. So if you have type O blood, you actually may be at decreased risk of infection, severe disease, compared to somebody with type A blood. And we don't know why. Now, early on in the pandemic, there was some very interesting reports about vitamin D deficiency being associated with severity of disease. So the next question you'd logically ask would be, well, if vitamin D deficiency is associated with worse outcome, then it stands to reason that vitamin D supplementation is going to improve outcomes. Well, the answer to that turns out to be no. Vitamin D supplementation doesn't seem to have much effect on risk of infection or outcome. And maybe that's because vitamin D deficiency actually might be a surrogate marker for the social determinants of health. Next slide. So for example, vitamin D may be low in somebody, not because of some underlying medical condition, but maybe because they don't have access to vitamin D enriched food or even outdoor spaces where they can absorb the sunlight and make vitamin D. So in other words, vitamin D low levels may be just a surrogate marker for other environmental conditions. So the social determinants of health, you may have heard that phrase before, and the CDC defines the social determinants of health as, quote, conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. So things like income level, access to clean air, safe neighborhoods, high quality schools, these are the sorts of social and physical environment factors that make up our day-to-day lives. They actually end up playing a huge role in how long we live and how healthy we're able to stay. Now, COVID-19 has exposed some very deep medical vulnerabilities that many in our society face. It's actually worth taking a minute just to take a look at this. Some of the epidemiologic data has indicated that Black and Latinx race ethnicities are associated with increased morbidity and mortality from COVID-19. But some studies have indicated that it's actually not Black and Latinx race or ethnicity per se that are driving medical vulnerability and outcomes, but it's the social determinants of health that these populations face. That's the real driver. Some studies come to a different conclusion, but I just want to point out one study that was in the Journal of the American Medical Association, JAMA. And this was done at the Medical College of Wisconsin, and it was a study of 2,500 consecutive patients who presented at the Medical College of Wisconsin Hospital and analyzed them for outcomes. And when researchers took a look at some of the risk factors that were there for an adverse outcome from COVID, what they found was that one of the major risk factors for an adverse outcome, which they defined as being sick enough that you ended in the intensive care unit, was poverty. So I want to leave you with one final thought before I turn the discussion back over to Dr. Cooper for the question and answer sessions. COVID-19 has truly exposed many of the healthcare vulnerabilities we have in this nation. And more than ever, when we look at the factors that make people susceptible to illness or death from SARS-CoV-2 infection, things such as high blood pressure, older age, poverty, excessive weight. When we look at these factors, to paraphrase Commodore Perry, we have met the medically vulnerable, and it is us. And I want to leave you all with the reminder that social distancing, hand washing, and mask wearing, those three things, social distancing, hand washing, and mask wearing, these are going to save lives, including your life, the lives of your loved ones, and those of all of us in this community together. So please, until This is under control. Herd immunity is out. Vaccination is widespread. Please remember to do your part by adhering to these very, very simple interventions. They truly will save lives. And with that, I'd like to turn the talk back over to Dr. Cooper to start the question and answer session.
Thanks so much, Joan. So first off, to our presenters, thank you very much for the really insightful presentations. And from our audience, there's a chat function associated with this presentation. It should be off to the right of your screen, or it may be at the bottom. There'll be an icon that says chat that you can click on, and then you can type in your questions. And then Vanessa will help us aggregate those questions. For our panelists, though, I'd like to start sharing some of the questions that we've received. Wow, lots to go here. The first question is, can somebody get COVID-19 more than once? So is it possible to get COVID-19 more than once? I don't know, Dr. Hanrahan, would you like to take the first crack at that question, or maybe some of the other panelists?
Sure, I can answer that question. So there have been two very well publicized instances in which we know that people were infected more than once. And there have been, other reports where people suspect that there was reinfection. There's an enormous difficulty with proving that somebody is infected more than once. And that's because in order to be able to demonstrate that definitively, you have to have a viral swab from when the person was initially infected, and then you also have to have a viral swab from the second time they were infected, and you have to actually be able to grow the virus and to demonstrate that it's two different strains. And to do that, you would have to keep all of the swabs when people get tested. So unless, people are doing this as part of a study, it's really not possible to do it. People get tested at multiple different locations. We are not holding on to swabs when people are getting tested. So logistically, it becomes really difficult. What we do know is that it looks like people are immune for about 3 months. But we don't know exactly, and we also don't know if people have asymptomatic or mild infection, they can lose antibodies sooner, or they may not produce antibodies. So a lot of this information is just still not really known definitively. And it is assumed that people can get infected more than once, and that's one of the reasons that a vaccine is recommended.
Thank you so much, Dr. Hanrahan. I will say in the chat function, Dr. Haynes just provided a really cool update. Dr. Haynes, thank you so much. The Moderna vaccine was just approved by the FDA, so congratulations to everybody. That's a pretty special present right before the holidays. That's really good news. So there was another really interesting question that maybe one of our panelists put forward, and I don't know, Dr. Duggan or others, could you contemplate this? Somebody indicates that their son and daughter-in-law are now sick with COVID. However, they were pretty obsessive about following the protocols. Are there ways of becoming infected? Can you still become infected even if you try to socially distance and wear a face mask and do the things that you've been asked to do?
Well, I'll start with this, and then I'll turn it over to Dr. Hanrahan. But absolutely, and that's one of the big problems with the respiratory virus. So people, when they're wearing a mask, may wear the mask incorrectly. Many times it slips down below the nose. People often have entry of somebody into their bubble just for a minute that they don't think has any risk of infecting them, but they may be asymptomatic carriers of COVID. And we do know that from some studies that were done, including with guards working in some correctional facilities, that the amount of time you have to spend with somebody may be pretty limited in order to get infected with COVID. When we talk about things like infection from fomites, so picking up something from the environment, it's much less than we suspect. And that's actually one of the great things about wearing a mask is you touch your face less with hand washing. You cleanse your hands before hopefully you take off your mask. So while people are obsessive and they think that they don't have any breaks at all in infection control, unfortunately, it doesn't take much. And so it is possible, even if you're obsessively doing the precautions, you can still get sick. And I'll ask Dr. Hanrahan to pick it up after that.
Yeah, so I would just add to that I cannot tell you how many patients I've talked to who've told me that they were being really careful. They were going to the grocery store early in the morning. They were disinfecting their mail, which, by the way, is not recommended. They were doing all of these things to try to make sure that they were not going to get infected, but they live with someone who was not doing any of those things and who was, going out with friends and, having get-togethers. So it really becomes more of an issue, the people that you have contact with. And some of those people, even if you may not know that they're doing some of these things. I would also say that I've had patients who relied on home health aides and who probably became infected from their home health aides. So just because, you're doing everything right, the other people who you have contact with may not be doing everything right. And that's one of the biggest problems that we've seen.
All right, thank you so much. Well, there's been some interesting questions for our virologists. For those of you who are expert in vaccine development, Dr. Huntley, maybe this one goes to you or one of the other virologists. A question from a audience member is, these messenger RNA or mRNA vaccines, are they safer? Are they more effective? There's concern out in the community about these mRNA vaccines, and how concerned should we be? And what's the sense of this from the virology community?
Well, this is Jason. I can kick it off. Again, I heard Anthony Fauci talk about the fact that one reason we have this technology and we're able to use it so quickly is the fact that Ebola taught us that we could use it and roll it out even in those populations in Democratic Republic of Congo and other places in Africa. So, we don't have millions and millions of data points like we do other vaccines. But again, this is not DNA. It's a different material than DNA. So as far as we know, for 50 or so years of working with RNA, there's no reports of that integrating into your own genome. So chances of integration, or that means the RNA going into your DNA, is zero. Chances of mutation, again, we don't have any evidence for that. So essentially all this is a small piece of a nucleic acid, and it's surrounded by lipids, which again, your own cells are made out of. So this is about as safe and as pure of a vaccine as you can potentially make. As you remember from my presentation, right, there's other ways to make vaccines, but I don't mean to knock those other methods, but they can be quite dirty in terms of, right, the flu vaccine is grown in eggs, right? So if you have an egg allergy, that causes problems, et cetera, et cetera. So each of the vaccine preparations and the way they're made, they have problems. This is new technology, and it's something to be afraid of. Again, it's been tested for, at least 3 or 4 years. And as far as we know, it's a very rapid and safe way to develop new vaccines.
If I could just repeat what Jason just said and echo, this is Saurabh. I totally agree that and mRNA vaccines are not new. They have been developed before, even for Zika, for example. But we just didn't need them. So this technology was around, and the vaccine was developed. There are some other vaccines in cancer field that also derived from mRNA. So there should not be any doubt that these mRNA vaccines can be toxic or there could be other effects.
Well, thank you both for your excellent advice and counsel regarding the vaccines. For our panelists, there's a couple questions in the panel regarding pregnancy and COVID. And I don't know if maybe one of our infectious disease specialists or others, or I haven't called on Russ Smith yet. So Russ is the UTMC expert in the vaccine. If Russ could give us any information about the use of vaccination for folks who are pregnant. And then Russ, if you answer that, then maybe one of our infectious disease specialists can talk about pregnancy and COVID, any concerns.
Okay, absolutely. So really, as a drug under the emergency use authorization, the data is actually very limited, and it's spelled out in the Pfizer that it's a conversation you need to have with your healthcare professional because it is so new. I guess I'll defer to our ID specialists of what their recommendations would be for those patients.
Yeah, so, you know, if you look at the current recommendations from the CDC actually has a very nice chart that goes over, you know, what the conditions are that you should be cautious about. And they specifically say that pregnancy, immunosuppression, I see questions in the chat box about immunosuppression or immunocompromised patients. Those are not contraindications to vaccine. And so we do know that pregnant women are at increased risk for severe disease and even fetal loss early on in pregnancy. So it is that is a condition where, you know, I definitely would have that conversation with the obstetrician, but that is not a contraindication to vaccine. And, you know, pregnant infectious disease pharmacists that I've talked to are planning to get the vaccine.
One of the things after, and again, I'm not an obstetrician, but the risk to the neonate seems to be less, so it's probably okay if a woman's had COVID and has delivered. She should be able to take care of her neonate, her baby, wearing a mask, and be with her baby. So it looks like the maternal effects are much higher than the fetal effects after the baby's born.
Thank you. Those were excellent responses. I very much appreciate that. Russ, we didn't have a specific section on the rollout of the vaccine. You're absolutely an expert on that and have devoted untold hours to, you know, how that's likely to happen. Do you mind just giving the community a brief overview about how the vaccines are rolling out and when people might be expected to be receiving vaccinations?
Absolutely. So the CDC is working directly with the Department of Health in Ohio and all the various states to set the guidelines for how the vaccine is going to be administered. So it could be through 3 separate phases. Phase 1 is going to be when we're focusing on a very narrow specific population. So we're looking at healthcare professionals providing care to the COVID patients. And as Dr. Duggan demonstrated, that very vulnerable population. One of the first populations to be vaccinated here in Ohio was the nursing home patients, targeting those elderly patients at the highest risk for bad outcomes from it. So those are the very first populations, and that's who was focused upon this week when the Pfizer vaccine was released. Ohio received just under 100,000 doses of the Pfizer vaccine that went to healthcare providers and those nursing home patients. The Moderna vaccine, assuming that the final approval from the subcommittee occurs tomorrow, that those will become available then next week for the hospitals and healthcare departments in Ohio. That's going to be focused on the COVID workers and the first responders. Then as more vaccine becomes available, it'll be going to the high risk. The FDA is going on and CDC is going to make official recommendations on how that rollout is going to go into later phase 1, phase 2, and phase 3. So the CDC Advisory Committee on Immunization Practices will come out with this. So far, they've really only published officially what the 1A recommendations are because that's all that is being vaccinated right now. But as we move into later in the winter and in the spring, more vaccine will become available for the community, focusing on those high-risk patients out there.
That was excellent, Russ. Thank you so much for those comments. We're almost out of time. I would like to put one more question to the group. And, you know, it's that time of year where families come together to celebrate the holidays. The question is, how do families or can families safely come together especially if they're vulnerable people within the family. So, you know, there's a pregnant lady or somebody over the age of 65 or somebody who has a chronic health condition. What is our thoughts about bringing families together in these circumstances? Can it be done? Can it be done safely?
So this is how the people who are meticulous and obsessive end up getting infected. It's the entry of somebody who's generally asymptomatic into the quote unquote bubble. And this is very, very difficult. If everybody quarantined, perhaps, but this is why the recommendations are coming out that this holiday we should, you know, consider maintaining social distancing to avoid spread of illness, and especially if you have vulnerable people in your household, there's a significant risk.
Yeah, I would just add to that, if you are having contact with people who are not in your household, so if you have people coming to your house who are not part of your regular household, there's a risk. And, you know, we get lots of questions about this. You know, I had a question, what if everybody's already had COVID, then is it safe? And the answer to that, even that, is unfortunately no, because we don't know with certainty how long immunity lasts after people have natural infection, especially if it was mild or if they were asymptomatic. So really the safest thing for this year is not to have holiday gatherings so that you can have future holiday gatherings.
All right, well, look, to our panelists, I'd like to express my appreciation for what you're doing on your work to help our communities and nation with this COVID crisis. Thank you so much. The information is evolving very quickly, thanks to the scientific community's continued discoveries and emerging treatments. To keep our community informed, we're planning several more town halls like this. We're thinking about the timing. Right now, it may be after the holidays, but if it needs to be sooner, we will do that. Please respond in the chat box or fill out a very short survey to let us know what you need to know. Again, our goal is to get you out information that you can trust. We will tailor the next town halls to meet your needs. So we'll use your feedback to help us understand what we need to share with our community. Lastly, as our panelists have indicated, we're at a critical state in dealing with this virus. Many of our hospital systems in our community are struggling to make it through this crisis. Patients are backing up in the emergency rooms, and for those even with conditions outside of COVID, they're having difficult times getting care because of so many beds taken by people with COVID. Our healthcare providers, some of whom are on tonight's panel, have been on the front lines battling this virus for nearly a year now. Tonight, I'm going to ask that you follow the guidelines and keep you and your loved ones safe. This also honors the caregivers who are working tirelessly to care for our families and our friends and our neighbors and our coworkers. Thank you so much, and happy holidays from the University of Toledo. Go Rockets.